8, 7. I'll tell you one. Go. So, good evening or good afternoon or good morning, ladies and gentlemen. It's me, the so-called CCC, and I'm gonna be talking to you with Dr. Y about the anxiety disorder. So, let's start by asking, what is anxiety disorder?
So thank you for having me. So what is an anxiety disorder? An anxiety disorder is basically an unpleasant emotional state. It's really characterized by feelings of fear and feelings of distressing physical symptoms. Now, the anxiety is only abnormal when it basically occurs in the absence of a stressful trigger. So it then leads to kind of impairing physical, occupational, and social functioning. And this can have a particular impact on people's lives if it is prolonged.
So, if you're saying if something happened to me, I broke my car, I had an accident with my car, maybe I'm stressed regarding exam coming, maybe I broke up with my girlfriend or she broke up with me, or maybe I'm going through this diet and I'm very stressed about it because I'm hungry and I know I need to lose weight, and that gives me a lot of anxiety. So that would be expected, so that's normal. So we only have an anxiety disorder when only it's only considered to be an anxiety disorder uh, when there's no trigger that will be stressful. So basically, if I just have anxiety and there's no actual reason for me to have it, nothing to rationalize it, then I could call it an anxiety disorder because there's no actual stressful trigger. Is
Yeah.
that right, what you're saying, Dr. Y?
Yes, so that's often how patients present. They have basically anxiety is characterized by these feelings of tension. So people will often describe it as tension feelings, worried thoughts, fearful anticipation. They'll often say they're more irritable, they're restless, they perhaps can't concentrate at work, they're not sleeping as much. They'll have kind of feelings of losing control as well. And people will often come in saying they're having these kind of depersonalization events where they don't really feel like they're themselves. Um, and they'll get obsessive thoughts and possibly even go into,
Rumination,
yeah.
thinking about the same thing all day long or all night long. What about these nervous tics, biting your nails all the time, like moving your legs all the time, having like restless legs? What about like having all sorts of aches and pains all over your body with no actual organic cause? Could those also be a sign of anxiety, or could it be something else you just say?
So if people have all of, as I said, those previous emotions built up inside, they can often manifest in physical forms. And for some people, that's just them trying to release that tensions that they're feeling. So it might maybe biting their nail, it may be shaking their leg. It can manifest in different ways. People also describe getting physical changes such as dry mouth. They might get tingling in their hands if they're breathing fast, or if their pulse will feel fast or harsh. They often can get chest pain, and palpitations is when the heart feels like a fluttering in their heart. They can also, a common one we see come in is the tightness in the throat. And they'll say they've difficulty swallowing. It'll feel as if someone's choking them. So that's a very common symptom that people report. And then they also can describe the pain in their in their stomach. They can get loose stools. Um, and headache and ringing in their ears is something they can also describe. So anxiety happens both emotionally and physically, and that's how it has such a severe impact on people's ability to function daily.
Now, is anxiety something that is very often found in the population, or is it something which happens very rarely, or only after a traumatic episode? What's the most common? Is it the most common thing that we've got in our society, in our world, anxiety, or not? What's the deal with the anxiety now?
Right. So today we're seeing an increase in anxiety, and the debate is out over whether it's now more acceptable to talk about emotions, or whether certain things in today's modern lifestyle is triggering people to have more anxiety.
What are the risk groups for anxiety?
So there are researchers find that there are certain people who are maybe more predisposed to developing anxiety. This would include people who have, say, a family history of anxiety. So if they've grown up in a household where another family member was maybe experiencing it and they were witness to that, it's unsure whether there's a genetic predisposition towards anxiety. If a person has suffered major life events, bereavements, relationship separations, and unemployment can often trigger anxiety. Women are actually more prone than men to develop anxiety disorders, but that's not to say that it's not common as well in men. It may just be that men don't report it as much as women, and maybe go without help for longer than women, if they ever get to reporting it to their GP. And then people also who have problems with alcohol and drug misuse. We always look for underlying mental health conditions in people who come in with addictions to alcohol and drug misuse. Often they're used as somewhat emotional crutches to help
alleviate the stress or
yes.
Okay, so when you said mental illness, I would like to clear it out now. Are you talking about personality disorders, or are you talking about mental illness as in, let's say, bipolar, schizophrenic, things like that? Or are you actually talking about personality disorders, like, let's say I'm in cluster A, cluster B, cluster C. Let's say I'm cluster C, I'm OCD, and I have an anxiety disorder obviously associated with that. Or maybe I could be a narcissistic personality disorder cluster B, and I have a anxiety disorder associated with that. Or I can be a borderline personality disorder cluster B, and I have an anxiety disorder associated with that. Could I have only anxiety, or it's usually you have a personality disorder which is associated with anxiety and sometimes depression? How would you describe it? Would be more often just anxiety, or it's actually an underlying conditions, like you actually said, which is giving you the anxiety, and then you have your addictions associated with it? How do you see it in yourself? Do you see that a person comes to you as a GP with only anxiety, or would you say they have anxiety, they have alcohol or drug misuse, they have a family history of abuse, emotional abuse, whatever, partner abuse, parents abuse, so childhood abuse, somebody died, somebody separated with them, somebody fired them?
Yeah.
Could it be a corroboration of everything together, or just some people just come with anxiety, that's what it is, no reason?
So a lot of what you mentioned can play as risk factors for people to developing anxiety. To say whether a personality disorder is separate from anxiety or whether there can be two at play. You'd have to look at the individual cases, but we get a mixture.
Okay, can you talk to me about the types of anxiety? So
the types of anxiety, there's lots of different types of anxiety, and it really just depends on the symptoms that the patient is reporting that's affecting their life, and that's how we classify them. So one of the more common ones would be a mixed anxiety depression disorder. That's
So
where
you're talking about the HADS test again, HADS,
Yes.
where you score the anxiety, score the depression. They usually come together,
yeah,
and luckily the treatment is kind of the same. The
Mhm.
SSRI sorts out the depression and the anxiety.
yeah,
Or if you only have the anxiety, SSRI, or if you only have the depression, SSRI.
exactly.
So they come together, they have the same treatment really.
Yes. And then you have people who come in with a generalized anxiety disorder, and they're more so the people who just have this anxiety. They don't know what's causing it. It's just pervasive throughout their life. So there's no single factor for the cause of it. There's also social phobia.
That usually comes with a personality disorder, isn't it?
Yes, yeah.
It comes in cluster C, isn't it?
Mm-hmm. Yeah. Sort of into the dependent, yeah.
Avoidant, maybe.
Avoidant, yeah. Then there is panic disorder. Now,
The panic attacks, you mean?
exactly. So that's someone with anxiety, with anxiety, which is triggering them to have panic attacks. If your panic attacks are severely impairing your life, you need to go to your GP to get help with that. Yeah. And then there is agoraphobia.
Crowds, yeah.
Yes.
Fear of being in crowds, in airports, in tight spaces with a lot of people close to you, or even large spaces with a lot of people close to you. So it's regarding and crowds of people. Crowds gives you anxiety. Anything can happen, you have no control, you feel unsafe, you feel anxious, isn't it?
And then you have phobic disorder, which is basically phobias that trigger anxiety.
But agoraphobia is also a phobia, I
Yeah.
would say. Yeah. Social phobia, it's also a phobia.
Yeah, PTSD.
Post-traumatic stress disorder, when something happens to you, isn't it? You have a pallet falling off you at work. You see somebody getting shot or killed in front of you, like Afghanistan, soldiers and things. They get a lot of PTSD. Army guys, police people, guards, whatever. They get a lot of PTSD depending on what trauma they had in their careers. You see a lot of that there.
Yeah, nightmares, flashbacks.
OCD, that's a personality disorder.
OCD is.
You're talking about the personality disorder or just the obsessive compulsive disorder, which is just not a personality disorder, just a compulsion that some people have.
Yeah.
And it's not actually classified as a personality disorder because it doesn't affect their lives in such a way that you can put a diagnosis and associate it with the psychiatric treatment. It's just some people are a bit more stressed about being overly clean, overly organized, overly perfectionist. They have their own set ways which you can't bend, so they're a bit uptight in those areas. So that's an OCD behavior, but it's not an OCD personality disorders. If you go on Wikipedia, you have a clear separation in between OCD and obsessive compulsive disorder as a personality disorder. Okay, is that what you meant there?
Yes.
Okay.
Yeah.
It's good.
Okay.
So treatment.
So treatment for anxiety. So from a medical perspective, if you attend your doctor, they will go with pharmacological and or psychological.
Or both, maybe?
Or both. Yeah, it depends on, some people don't want to attend counselling. Some people want counselling and don't want drugs. Some people
What would
just
be the
want drug.
primary advice you as a doctor to the patient when they come to you in anxiety? Do you offer them both, or you just offer one of them first?
Depending on the severity, you would ask the patient to see what they prefer as well. And that always plays a factor. If someone's not going to get benefit from counselling, there's no point in
Yeah,
referring
but what would be your standard offer?
Probably both, medication and counselling. Both feed into a more successful outcome.
I would, from my point of view, I would do the HATS test. I would see how bad is the anxiety. It's like 11 to 12, 13 is like borderline anxiety to abnormal. Then I would speak to them, see if they just want to start with counseling rather than starting on tablets. If the HATS test anxiety score is off the roof, let's say 17, almost maximum, very abnormal anyway, then I would suggest both. If they refuse counseling, that's fine. It's their option. You can't force them to have counseling. But I would definitely start the tablets for sure. But if the score is not that high, I would start with counseling and not the tablets myself. That would be my practice. And or both. I would negotiate that with them. But if it's not that bad, if it's not causing too much stress and they can sleep at night, I would just go ahead with 6 sessions or whatever, if they have a medical card, or to go with just counseling, because sometimes the anxiety comes just from cognitive distortions. It comes from, over-worrying, catastrophization, all those black and white thinking, projection, transfer, counter-transfer, all sorts of psychological mechanisms which are a bit which are abnormal, and they need to be fixed. So if you fix those, the anxiety levels go down, and that's it. If it's a organic anxiety, like a generalized anxiety disorder, just a low serotonin, a high cortisol, high adrenaline, I don't know what's happening, no actual reason, it's just an organic, then obviously pharmacological plus psychological, but I would go always with the tablets. But you have to see how bad it is, basically, and you have to decide. You want the tablets to be the last resort. If it's too severe, you always need to use the tablets. But if it's not that severe, you have to think psychological is probably the best. We just fix our neuron connections by talking to somebody. We change our way of thinking, change the way we see things, and then you might not need tablets. Why? We can fix the problem at its roots. Okay.
Yes.
Can you continue, please?
Very true. So if we do go with the tablets, there's certain antidepressants that we actually use to treat anxiety. Often patients are wondering why their doctor is putting them on an antidepressant, but it just means that.
So citalopram, escitalopram, sertraline, venlafaxine, and all sorts.
All of those.
You just SSRIs? You use SNRIs or other types of antidepressants?
Yeah, you can use SSRIs and SNRIs.
Okay.
Also, some patients might need a short-term adjunct of benzodiazepines.
Your Xanax.
Valium. But that's only ever given short-term. There's a high risk of dependence. And
Xanax
addiction.
as well, yeah, just to clear,
Xanax, yeah. So basically, your doctor will start you on either both or one, and they'll review you regularly to see if you're improving. Now, what's important with anxiety is to also look at your lifestyle. A healthy lifestyle is what is recommended. Often we encourage patients to engage in things like yoga, meditation, being mindful, and looking at their diet as well. So if they're having a lot of caffeine, I once had a lady who was drinking over 7 cups of coffee a day, came home and was not eating anything healthy for dinner, was having sugar, and she was wondering why she couldn't sleep and why she was feeling so terrible. So looking at the basics is also important. Exercise, really does help get rid of some of that tension feelings.
It releases serotonin
Exactly. Yeah.
when you exercise, isn't it?
Yeah, and it helps with muscle relaxation. So, you know, it helps regulate your
Catecholamines anyway,
breathing.
isn't it?
Yes, serotonin, dopamine, all of that gets released with exercise. So it's getting to know your anxiety really is important for patients.
So when do we refer to the local psychiatric?
So
To the specialist.
So referral to specialists occurs when really the patient isn't improving.
How long would you give it? A month, 2 months, 3 months? Would you increase the dose? Let's say escitalopram, 5, 10, 15, 20, stay on 20 for 2 months. What do you do?
So the treatment, really within, I would say 3 months. There's no specific guideline out there on referral.
So you reach the maximum dose in 2 months.
Yes, yeah.
You see if there's any improvement at all. If it's not, then you refer, isn't it?
Exactly. You refer for further.
But the third month, you give it a chance so you can switch the antidepressant to a different one, yeah?
Yeah, and the referral to
The SSRIs, okay.
Yeah, the referral to secondary care can also be for people who just need or are just taking longer. Secondary care can provide a longer input.
And a better counseling, a better CBT or something like that.
Exactly.
Yeah.
So if the patient needs that,
Especially CBT rather than just a
it's
basic
better. Yeah,
counseling.
yeah,
Yeah.
exactly. And if you manage to successfully treat the patient and they come back to you and say they're feeling better,
Well, do you know who actually gets to see a psychiatrist for anxiety? It's the people who actually have a personality disorder, and the anxiety is just one of the symptoms. So the
Yeah.
anxiety, depression, that's not the main problem. The main problem is the personality disorder. So those need a bit more work done and a bit
Yeah.
of more
a bit more
professional
intensive or a bit more long-term treatment that can be provided from secondary
CBT,
care.
DBT, mindfulness, whatever
Yeah.
the service the consultant thinks it's better for them.
And if you are successful with your treatment of the patient in primary care, you
Decrease the dose in 6 months, just like with the antidepressives, or?
so you want to keep them on the actual medication for 6 to 12 months after recovery.
And then you taper down the dose 6 months.
And then you can start tapering it slowly. Yeah.
Very good, very good. Sounds like it's very similar to depression, to be honest with you. Why would you say?
Yeah, it is, and
Very good.
it is very similar. The two do go together.
Well, thank you very much, Dr. Y. And
No problem.
I'll let you go. So,
Okay.
all the
Thank
best.
you.
Thank you. Bye.